Let's close out this section a little bit. I want to kind of lump a couple things together, and really is, I think we've talked about it a little bit, but I think, Paul, you may be in the best position right now. Let's talk about large versus small practices and the willingness to adopt new treatment and technology. Is it different for a small practice versus a large practice? You know, what are the things that a smaller practice, now that you've gone from 7 to 12, will you look at things differently than what you used to do when you were much smaller in terms of the cost of instituting, incorporating some of these therapies? And then let's also talk about how community practices are moving towards, is there more movement? I know, Mark, you've already said you've done this, moving towards this multidisciplinary approach, very much like a lot of the academic centers. Is that going to become the standard within the community practice, especially in light of what may or may not happen in healthcare reform? So, Paul, let's start off a little bit. You're at 12 now, you were at 7. Is that going to philosophically change how you look at new technology moving forward?
Well, you know, I think when we started with 7, it was easier because we quickly, or maybe not quickly, maybe by just economic forces, or maybe the internet, people coming in saying, who in your practice does this the most often? So with the 7-man group, we were more able to specialize. And I think it's a lot easier with 7 men to be more nimble. Now with 12, the nimbleness will be a little bit challenged. And will the other 5 new members accept, oh, I'm going to be stratified into this category or that to do a specific procedure? But when it comes to having better outcomes, I think we want people who deal with a process on a regular basis. So for us, for my practice with 7, it was very easy for people to funnel to me all the advanced prostate cancer because I knew all the new technologies, and that was the most ideal way to manage people. It was uniform and it was on the cutting edge. And I think the dilemma came as when we were all 7 trying to do what we thought was the latest and greatest, we fell short. Now the question is, can I herd my next group of 5 more cats into saying, okay, 1 or 2, or you will be experts in this, that, or whatever. And I think that's the same issue when we look at the community level, setting up a multidisciplinary clinic. You know, when you see an oncologist out there in the real world who on the average sees maybe 1 new advanced prostate cancer per month, and he's an expert, I mean, how do you get an expert in that setting to say, I see 1 a month? So they too have had troubles that I find my oncologists don't want to have that be niched to say, I'm a prostate cancer guy, I'm a breast cancer gal, I'm a GI guy, and maybe the academic center has been able to push that, but I see the community guys, at least at our level of practice, able to push that harder and harder, and my goal, or my hope is, as I go to 12, I can funnel down to, this is our prostate cancer guy, our testis bladder cancer guy, this is my BPH guy, and I think we deliver the same quality, the same thing they do at an academic institution, because our people see vast numbers of people when we funnel everything to 1 or 2 guys. Or gals.
Mark, in Kansas City, so clearly I know you've talked about how you do things operationally. Does the cost factor, getting back to this, circling back to cost, does that influence your group in terms of how, again, you might incorporate a particular therapeutic or technology in your practice?
I don't think that comes up as a primary motivator for any of the treatments that we do today. I think that, you know, we're fortunate because in a large group we do have our ancillary care services, and we have some income that we derive from that. So taking care of patients with less good insurance or uninsured isn't as big an issue as it might be if we were a small practice and our overhead was high. So we can absorb some of those underinsured patients, and I think that that's an advantage. But short of that, I don't think that cost comes into play too much when we're treating patients today.
When I've presented some of the newer therapeutics, I have had some of our colleagues who, in urology, I think we're a little bit different from, say, medical oncologists who bristle significantly when they hear about some of these costs. And they look at it a little bit in a void, not so much what it might cost the individual clinic, but just the overall cost. I think medical oncologists who are used to treating systemic malignancies have long understood the expensiveness associated with that. I think it's a little bit of an economic education of a business model for some of our colleagues. But you spoke of this earlier, Raul, and you know, for a long time, 20, 30 years, urology was primarily a surgical specialty. And we love to do procedures, but let's face facts. The amount of open operative surgery is diminishing dramatically. All one has to do is look at the American Board of Urology and see what the certification numbers and the lists show. We're doing many more outpatient endoscopic therapeutics, and we're just seeing a lot of patients, and we're doing non-invasive therapies, pharmacologic, et cetera. So it just seems to me, getting back to what you were talking about, Paul, when you first started, and I know, like myself, you've been really interested in therapeutic pathways, but your new partners, like my new partners, and for the future, if they're not going to get on the bandwagon of understanding of all these new therapeutics, what will become of urology as a specialty? It can't just be relegated to doing robotics. Not everybody in a large group can be the robotic guy, or as I sometimes say, not everybody can be the guy who does, or the gal who does the complex pelvic prolapse repair, especially if you're in a 10, 20, 30-man practice. You have to have somebody who's taking the initiative to understand advanced cancer.
I think the economy, though, comes in when you have the expert who is comfortable dealing that day in and out for your practice. So there's an economy for your practice from the standpoint of he sees it routinely, and he has a standard algorithm. I do this, I do this, I do this, versus the guy who's seeing it episodically, rarely, and struggles to say, let me think about this, or I'm not sure, I got to go ask somebody else. And the economy is they're inefficient. Just the same as taking myself doing a pediatric hydrocele would take me an hour, and my expert in my group who does them all the time does them in 20 minutes. I mean, the economy for us is we're more efficient because we see it routinely, we have in our mind, this is our plan, boom, boom, boom. And that's the economy of CLIC.
And perhaps you can eliminate unnecessary testing in that regard. I mean,
You also control their test costs. I mean, the economy is I can go to an insurer and say, I want to do this and this is my order, this we deem is appropriate for us, versus having 7 people, 7 different approaches, 7 different testing patterns.
Sure. It gets what you were saying. You get better outcomes and better cost control.
I think that we all know the day of the general urologist that knows how to do everything. My license says in pediatric urology. I don't even know what to do in pediatric urology anymore. I'm so specialized that even stones are becoming distant to me, are a thing of the past. That, that's to me one of the advantages of the large practice groups and other things like that, unless you're just in a small town where you have to be a general practice and urologist, is that you have people that focus and have expertise. And we all know, you just pick up any journal, when you do more and more and more and more of something, you get better than the person that does one a year or one a month. The multidisciplinary model may not work in your practice, but a lot of large groups are getting medical oncologists and pathologists involved. I think the major advantage of a multidisciplinary clinic, in fact, is our once a week getting together and reviewing the new patients and have a pathologist look at it, a radiologist look at it. We find misreads in pathology, lesions missed, overdiagnosed on radiology every week. And so what that does is you maybe not have to have that in your practice, but I think it would make sense to get together with your local pathologist and radiologist and review all these things. And that's, it does provide better outcomes.